Oh, hi! Welcome to my laboratory. Just kidding, it's not mine, I just work here. My name's Jeff. I'm a clinical scientist here at Bonner General Hospital. You're probably watching this as part of your orientation day as a new hire. Congratulations and welcome to our healthcare team. This presentation is geared mainly towards nurses, but if you're not an RN, I hope you find it at least entertaining and hopefully you'll learn something as well. I'll be covering the do's and don'ts of most of the specimen collection techniques utilized by our medical staff, in hopes of minimizing sample rejection by our laboratory. It's a major point of conflict between our department and the rest of the hospital. Now, no one likes working with poop or pee or anything else you could squeeze out of a human being. But here in the lab, we commend you nurses for being the ones to collect it for us. So in order to minimize the chances of having to throw away your precious samples, we present to you the Hitchhiker's Guide to Specimen Integrity. We'll start with the most common specimen, blood. Most often, one of our highly skilled and professional phlebotomists will draw the specimen, but in clinical settings and during IV starts, sometimes RNs will collect it. I won't go deep into phleb technique, but instead focus on the critical window of time between when the blood leaves the body and when it is placed into sample tubes. Blood will begin to clot when it is removed from the patient, unless quickly introduced to an anticoagulant. Each colored tube corresponds with a different anticoagulant, and each is compatible with a different subset of tests. Order of draw is important, and among the common tubes used, it goes blue, red, green, lavender, and gray. Those 5 tubes, properly collected with adequate blood, can enable a doctor to order pretty much any diagnostic blood work they could want, all on around 10 milliliters of blood, but only if it's collected correctly. If you can only get a little bit of blood, we can usually prioritize and get some of the testing done anyway, but one common tube where the volume is critical is the blue top. It's for coagulation tests and requires a precise ratio of blood to anticoagulant. Assure the blood fills the tube within the range of the black arrow on the side of the tube, as shown. For example, this tube would be rejected, delaying testing. Here we have a few specimens post-centrifugation. This green top is perfectly acceptable, adequate fill with clear yellowish plasma. This red top next to it is nearly indiscernible from the green, also acceptable. The difference is, this tube was allowed to clot before it was centrifuged. Serum comes from clotted specimens, whereas plasma is prevented from clotting by the tube additives. Some tests require one or the other, while some are compatible with either. On the right, we have 3 problem specimens. This one is hemolyzed. A slow, difficult draw or overexerting on the syringe plunger can cause the red blood cells in the sample to burst and spill their contents into the plasma, which can throw off many tests, namely potassium. Next, we have an icteric sample. Plasma of patients with hepatic issues can sometimes take on an orange or amber hue. While no amount of phlebotomy skill can fix this issue, some tests will be erroneous due to an icteric sample. Lastly, we have a lipemic sample. This one is an extreme case, likely linked to hyperlipidemia, but even healthy patients can have slight lipemia following a greasy meal, which is another reason fasting blood draws are important. Like hemolysis and icterus, lipemia can also make many lab values erroneous. We assess each sample case by case, and will do all the testing that isn't hindered by these conditions and inform the provider when a redraw is required. The take-home message here is, be gentle with the syringe, warn the lab if there was a slow, difficult draw, fill your tubes adequately, and invert all tubes thoroughly and promptly. Another thing we'd like to cover today is specimen labeling. You can see on a blank tube there's a window to the inside on the opposite side of the handwritten patient information label. We like to keep that open. So, although sometimes you're in a hurry in a trauma situation, try not to cover that window. That's a no. Because if we can't see the fill level on these tubes when we're trying to centrifuge, we can't balance them properly. We have to rip off your label, add our own later, waste a little bit of time. So try to keep that open, especially on a blue top. Because if we can't see that black arrow, we don't know if the specimen's good or not. So, take a little extra time, put the label on the side of that window, and roll it around. That keeps us happy. On to the second most common specimen we receive, urine. Urinalysis can sometimes tell a doctor a lot about a patient's disease state. The ancient Greeks would sometimes taste urine to assess its contents, looking for hints of sweetness to diagnose what we now call diabetes mellitus. Pee is my least favorite specimen because of how often it is collected in a sloppy manner. It gets on your gloves, you have to change them all the time, it's kind of a pain. It's pretty simple. Collect the sample, don't fill it all the way to the brim. sure proper threading of the cap. You can back it off a little bit to do so. Shut it all the way. Don't over tighten because it'll pop off the threads. Wipe the cup. Label it neatly, whether handwritten or an auto-generated label, and place the specimen upright in a biohazard bag. Pretty easy. Now here's a few examples of what not to send us. Not cool, man. Not cool, man. Really? Really? For crying out loud, meet me in the middle here. Ah! Stool. We don't like processing it any more than nurses like collecting it. Just like urine, please disinfect the outside of the container after collection and mindfully thread the lid and shut it securely. A walnut-sized sample is adequate for any testing the doctor could want. Don't fill it to the brim. Pro tip, if you shake the cup and the specimen audibly rattles, we'll reject the sample for a C. diff test. Any patient passing stool of that consistency does not have toxin-producing C. diff. Trust me, I'm a scientist. Next, let's talk about sputum, aka snot, loogies, or my favorite, lung butter. In a patient with pneumonia, true sputum is composed mainly of white blood cells and the causative agent of their illness. This is not to be confused with spit. Sputum comes from the lower respiratory tract, and although it must pass through the mouth, a prime specimen has minimal saliva, as mouth flora contamination can create a microbiology nightmare when inoculated for culture. The best sputum samples are collected first thing after a patient wakes up, when coughing has ceased for hours and the goop has accumulated in the airway for a while. We'll assess the sample microscopically to ensure validity, but if you can tell it's more spit than sputum, save the patient, yourself, and the lab more time by trying to collect a better one for submission. Wet mounts are a quick microscopic look at a vaginal swab to detect bacterial vaginosis, yeast, and a trichomonas infection. Place the swab or swabs after collection in a plastic tube, break them off, with just enough saline to submerge the cotton tip. Simple as that. It's crucial that we read this test within 30 minutes of collection, as trichomonas dies quickly outside the body, and we can't discern it from a white blood cell if its flagella aren't actively moving. Always consider this test stat. MRSA swabs are a quick, simple way to determine a patient's carrier status of this potentially dangerous, resistant organism that causes many nosocomial infections and extends hospital stays. We currently use the liquid Stewart's culture swab with the white top. Simply swab both nares with a twisting motion with one swab. Place in the tube. Simple as that. Label it appropriately and drop it off at the lab. Nasopharyngeal swabs are used commonly for the detection of Bordetella pertussis, known as whooping cough. They're also used to detect RSV, respiratory syncytial virus. Much more invasive than a nary swab, the tip needs to reach the back of the throat through the nostril. Warn the patient of the procedure and have them tilt their head back. The most common patient for NP collection is a child, so having their head rested against a wall or the bed can help keep them braced in case they try to pull back or resist during collection. I will now attempt to perform this procedure on myself for your entertainment purposes. Oh, oh, geez. That is as bad as they say it is. You're welcome. Label appropriately, bring to the lab. Well, that's all the time we have for this video. We haven't even scratched the surface on all the possible specimens that you might have to obtain from a patient. But the aforementioned collections are the most common and the most commonly rejected. For a detailed description of each one, please refer to the procedure published in PolicyTech, as preferred collection methods and equipment sometimes change. Thanks for watching, and again, congratulations on joining our team at Bonner General Health.